Thank you for joining our webinar on the opportunities and challenges for pharmacist-led immunizations, perspectives from the Pharmacist Clinic. This is a re-recording of the webinar we hosted on October the 22nd, formatted for optimal asynchronous viewing. I am pleased to introduce our presenters, my colleagues Adrian Ziemczolnik and Timothy Lim, who are clinical pharmacists and lecturers at the UBC Faculty of Pharmaceutical Sciences. Adrian is our immunization lead, currently working on initiatives with UBC HR to update vaccination information and services for all UBC employees, with the ultimate goal of increasing vaccination uptake within the UBC community. Tim is our outreach lead and works with underserved communities across the province to optimize pharmacy clinical services and health outcomes. Tim and Adrian have both participated in our annual flu clinics and traveling health fairs, where immunizations are administered and immunization assessments are routinely completed. And now I'll pass it off to Tim.
Thank you, Nikki. Before we begin, I would just like to acknowledge that the University of British Columbia and the UBC Pharmacists Clinic are on the traditional, ancestral, and unceded territory of the Musqueam people. And I invite you to take some time to reflect your relationship with the land that you are zooming in from today. In terms of conflicts of interest, we have no conflicts of interest to declare, and we are not receiving any payments outside our usual salary to give this webinar. To provide some context, at the Pharmacist Clinic, we have been incorporating an immunization needs assessment into our annual flu clinics for several years, and today we will be discussing some of the opportunities and challenges for pharmacist-led immunizations. As such, the outline of today's presentation includes discussing the importance of adult immunization, implementing immunization assessments, care of patients with unknown vaccine history, as well as the care of patients with vaccine hesitancy. This should take around 40 minutes, and then we have 10 minutes for the Q&A. The objectives for this webinar include understanding the rationale for integration of routine immunization assessments in community pharmacist practice, describing strategies for implementing routine immunization assessments, providing care for a patient with unknown immunization history, and understanding the concept of vaccine hesitancy, as well as explore ways of approaching vaccine hesitant individuals. So let's start off with the importance of adult immunizations. In order to understand the rationale for integrating routine immunization assessments in community practice, we need to take a step back and understand the importance of adult immunizations. As a cautionary note, we will be focusing on adult immunization rates and not children, as child immunization rates are generally higher and there are more robust measures and programs to ensure children receive their immunizations compared to adults. So immunization coverage rates for adults in Canada. This slide here looks at the immunization coverage rates for the annual influenza vaccine. In Canada, our annual influenza vaccination goal for individuals at high risk of influenza-related complications and hospitalizations is 80%. This target is the goal set for us to achieve by 2025, and high-risk individuals have been identified as seniors 65 years of age or older, and adults with chronic medical conditions like COPD, CKD, cancer, organ transplant recipients, diabetes, heart failure, and cardiovascular disease patients. Taking a look at Figure 1, flu shot coverage for seniors 65 years of age and older is around 70%. So actually, we are pretty close to target. But if you look at Figure 2 on the right-hand side, the percentage of adults receiving the influenza vaccine who are 18 to 64 years of age with a chronic medical condition is much less, consistently sitting slightly under the 40% mark, which is halfway from reaching our target. To further drive this point home, while Canada's immunization coverage goal for the pneumococcal vaccine for individuals 65 years of age or older is 80%, on average, data ranging from 2006 to 2016 consistently shows we are only halfway to the immunization goal, with vaccination rates sitting at around 40%. I think this is important to highlight because the pneumococcal vaccine is publicly funded and is one of the more commonly recommended vaccines in practice. However, even with these two factors in mind, we are still only halfway to our target. So going back to the question of why adult immunization is important. If a patient comes up to you and asks you this question, what sort of talking points would you provide? To start, adults need to keep their immunizations up to date for several reasons. Some vaccines can wear off over time and do not offer lifelong protection. For example, adults require tetanus boosters every 10 years and should receive the influenza vaccine each year. Some diseases are also more common in adults, and some adults do not receive all of their vaccinations recommended in childhood. People who have lived in another country as well as a child may not have received all of the immunizations recommended in Canada. Further, herd immunity is important. Fully immunized adults can help protect the vulnerable populations such as infants and the elderly, as well as those who are immune compromised. Lastly, more recently, newer vaccines like Shingrix and Gardasil have become available, and we should assess if our patients are eligible for them, keeping in mind that vaccine-preventable diseases can occur at any time because the bacteria and virus that cause these infections have not been completely eradicated. And so what is the impact of COVID-19 on immunization rates? Well, as we are still navigating through this pandemic, it's hard to have a definitive answer. But what we do know is that the effect of the pandemic on healthcare delivery is multidimensional. A couple key points to remind ourselves here is that first, there has been a disruption of immunization services. Self-isolation and fear of transmitting COVID-19 has led to fewer visits to the clinic and healthcare providers. Healthcare providers have also been deferring visits to decrease the risk of virus transmission, thus converting in-person visits to telemedicine visits. Conversely, there is simultaneously a heightened awareness and demand for influenza vaccine. Increasing demand for the influenza vaccine was seen in countries from the Southern Hemisphere, like Australia, where the winter season is now coming to an end. From March 1st to May 12, 2020, Australian immunizers administered nearly 6.5 million doses, which is double the number of vaccines for the same period in 2019. Moreover, a national survey of nearly 2,000 Canadians showed that 57% of respondents said that they will definitely or probably get a flu shot this year, compared to 45% who said they were immunized last year. Of those who were not vaccinated last year, 26% said that they will definitely or probably do it this year, citing COVID-19 as their main motive. So to say the least, people are looking for ways to protect themselves and stay healthy, as there are concerns around overlapping comorbidity between influenza and the coronavirus. The important thing here is to acknowledge that uptake of vaccine-preventable diseases should not end during a pandemic and is one of the most powerful tools in the history of public health. This is why, as pharmacists, we should be mindful of ensuring our patients are protected against these diseases while respecting COVID-19 physical distancing, hygiene, and PPE measures. And with that, I'll pass it on to my colleague, Adrian.
Great, thanks, Tim. So now I'm going to talk about why pharmacists should consider having a process for assessing immunization status in their practice if they don't already, and what it might look like. As Tim just explored with you, adult vaccination rates in Canada are not at target, and pharmacists are very well positioned to help enhance immunization status for adults. Unlike routine childhood vaccinations, which are completed through the infant and school-age vaccine programs, there's a general lack of infrastructure when it comes to similar programs in place for adults. And therefore, most adult vaccines are provided by the patient's main healthcare providers. And so that responsibility falls primarily on either their family physician or nurse practitioner, or you, the pharmacist. And so we have a big responsibility to help keep our adult population protected and a duty to regularly review our patients' immunization status. And this role is well suited for pharmacists, as we are regarded as highly trusted sources of information for our patients, and we're considered one of, if not the most accessible healthcare providers. In British Columbia, we have access to a wide range of both publicly funded and private pay vaccines. In fact, BC pharmacists have access to all publicly funded vaccines through their local community health units. In addition, here in BC, like most provinces, we have a payment model to support immunization services with an injection fee covered by Pharmacare for administration of the publicly funded vaccines. Vaccine assessments are a critical first step to ensure protection against vaccine-preventable diseases. As you've probably noticed, navigating immunization schedules can be tedious at times. And unless your patients are consistently and proactively reviewing these documents or receiving frequent reminders from providers, there's a good chance they will not be aware of which vaccines are recommended for them or which they're eligible for. Just like any drug therapy, vaccination needs have to be reassessed consistently. This is in part due to changing immunization schedules and development of new vaccine products, but also because your patients' needs change over time. Factors such as age, medical history, lifestyle, and occupational risks can all impact a patient's need for a vaccine. So when is a good time to assess a patient's immunization status? Well, consider adapting the mindset that some form of vaccine assessment or a screening process can occur at every routine patient care encounter. For example, consider reviewing immunization status when building a patient profile for a new patient or during prescription intake process. Conducting regular medication reviews is another ideal time to assess vaccination status. Reviewing vaccine history should be part of all medication reviews, as a necessary and recommended vaccination is an unmet need and translates into an easy, actionable medication-related problem. A med review can also help identify changes in a patient's health status and chronic conditions which may end up impacting vaccination recommendations. Finally, the big one to focus on currently is while providing another vaccination. If a patient is already coming in for an immunization, it tells you they're generally accepting of vaccines, and a quick screening or assessment can help determine additional eligibility on the spot. This is a terrific opportunity, keeping in mind that we can administer multiple inactivated and live vaccines at the same time. And so this is especially important during this year's influenza campaign. As Tim mentioned, what we've seen in Australia, there's likely a heightened awareness around vaccine-preventable diseases and an increased demand for influenza vaccine, and hopefully other vaccines as well this year. Maybe some of you have already seen this in your practice. As an example, for our organized flu clinics, which are starting next week, all our 500 appointments were booked within 48 hours. And 50 individuals with booked appointments requested to have at least one additional publicly funded vaccine at the same time. That was either tetanus, pneumococcal polysaccharide, or MMR vaccine. And this is a much higher number than we have seen in previous years for these additional vaccines. So in our practice at the clinic, we ask about immunization status and history during each clinical encounter with patients, and similarly use our assessment flowchart during yearly influenza clinics and during outreach events. In addition, we also book specialized 15 to 30-minute appointments with patients for vaccine consultations. These focused appointments are sometimes needed to determine vaccine eligibility or recommendations for more complex patient cases, such as those with unknown vaccination history, or for patients who may have missed part or all of their routine childhood immunizations. We will review an actual patient case we encountered in the next section of this webinar. The next two slides I have here are just some provincial resources you probably have seen before, tables that are widely available from online websites such as Immunize BC, Vancouver Coastal Health, and BC CDC. If you don't already have a quick process to screen or assess your patient vaccine needs, this is a great starting point. I do just want to mention that you should be mindful of the dates these were created because they can very quickly become outdated. So here we have one handy table from Immunize BC. And here on this next slide, I have another example from Vancouver Coastal Health. Again, use these as a starting point, but if more specific questions arise, always refer back to the BC CDC Immunization Manual, Part 4 on biological products for up-to-date eligibility criteria and very detailed monographs for each vaccine product. So here I want to share with you a quick assessment flowchart that we developed and use at the Pharmacist Clinic during routine appointments. If interested, just want to note that this is available on our UBC Pharmacists Clinic website under the Practice Resource section if you want to either use it or view it in more detail. A couple things I want to point out first is that this is not a fully comprehensive chart to determine all possible vaccination needs for a patient. And as noted on the side, we use this chart specifically for our adult patients who are up to date on their routine childhood immunizations. Again, for patients with unknown or incomplete childhood immunizations, we may have to organize a separate vaccine consultation, as mentioned earlier. Our flowchart is tailored to fit the need of our practice, specifically a quick review to help identify possible unmet vaccination needs that could be provided at the same encounter in which the assessment is done. As we are not a dispensing pharmacy, our flowchart focuses primarily on vaccines that are available from the local health unit and can be provided free for the patient under public eligibility criteria. Although we do also review and provide education for other private pay vaccines, such as shingles vaccine, and refer patients to appropriate services to access them. So to briefly walk you through it, we start with a general recommendation of an influenza vaccine for all eligible BC residents during the flu season, and then do a quick review of needs based on the patient's age and chronic medical conditions. So on this first slide, you see, based on the patient's age, we might recommend either a tetanus booster, a shingles vaccine, or a pneumococcal polysaccharide vaccine. Then this is followed by a review of the patient's medical history to identify high-risk individuals based on chronic medical conditions. This helps us easily determine and narrow in on which vaccines to screen for based on the list underneath each chronic condition. We would then review eligibility criteria and the patient's past immunization history. As a take-home point, I would encourage to build a similar tool which can assist you in the screening process for your adult patients, tailoring it to fit the needs of the patient groups you typically encounter at your practice site. So with that, I want to wrap up by discussing some tips we have found helpful in our practice. First off, unless you're able to confirm vaccination, adopt the mindset that every patient is under immunized and you should offer to discuss vaccine opportunities. Second, include all staff in your process. Have other pharmacy staff conduct short guided assessments to patients when they're either picking up medications or dropping off prescriptions, or consider adding additional screening questions to your vaccine consent forms. Again, it could be as simple as adding a question whether the patient knows when they had their last tetanus vaccine, or having the patients complete a checklist of chronic medical conditions, again, to help identify high-risk patient groups. Consider having a point person, someone that is in charge of maintaining and regularly updating inventory of vaccines and supplies. This will help ensure that vaccine product is always available and the vaccine can be given opportunistically at the same time the need is identified. So for us, that includes always ensuring we have the influenza during the season, tetanus vaccine, pneumococcal polysaccharide, and MMR on hand. Don't forget, you can order additional vaccines on a case-by-case basis. If you find a patient is eligible for a publicly funded vaccine, this can be ordered from your local health unit and provided free, which is an important consideration given that cost can often be a major barrier to vaccine uptake. And with that, I'm going to pass it back to Tim.
Thanks, Adrian. Next, we are going to discuss how to work alongside patients with unknown vaccine history. So let's start off with a case. PL, a healthy 33-year-old female engineer with no comorbidities, wants to be current on her routinely recommended vaccinations. In terms of history of present illness, we find through info gathering that she left Canada in grade 7 at 12 years of age, believes all her immunizations were up to date until that point, but does not have her records on hand, does not have any foreseeable travel plans, and shares that cost is a concern. So, what are some tips for patients to locate immunization records? We encourage patients to keep a personal immunization record and present at each healthcare immunization visit so it can be updated on the spot. Some of the tips for finding immunization records include checking common sites such as the home, parents or other caregivers' home, family doctor's office, the pharmacy, local health unit, employer, or school. In British Columbia, childhood immunizations are most often recorded in the Child Health Passport, and that might be a great place to start. We should also recognize our role in helping adults keep track of their immunization. Something to consider is that many adults may be getting their vaccines for the first time outside their routine childhood immunizations in school when they come to your pharmacy. It's important for pharmacists to emphasize keeping a detailed immunization record and help them develop a method going forward. You can provide patients with paper immunization record cards available from Immunize BC, or consider introducing the app found on canimmunize.ca. So what do we do if patients can't access their immunization records? Well, without a record of immunization or proof of immunity to a disease, a person is considered unimmunized or unprotected. In that case, they should be considered susceptible to disease and they should generally be vaccinated or revaccinated to ensure protection. We can advise them that it is safe to repeat vaccines and also let them know that blood tests to determine immunity to vaccine-preventable diseases are not routinely recommended and is not available for all diseases. So, going back to the case, PL calls her parents and is able to confirm all immunizations are up to date, including the ones that are given in grade 6. More specifically, they confirmed that she received the Tdap primary series when she was in kindergarten, but not the booster when she was in grade 9. So going back to this case, how do we approach it? After collecting all possible sources to confirm immunization status, we first identify all vaccines the patient is eligible for. In this case, PL is eligible for the following: the TD or Tdap booster, HPV vaccine, influenza vaccine, and the meningococcal quadrivalent conjugate vaccine. Next, we want to describe the risk and benefits of receiving each of these vaccines, and let's use the TD or Tdap booster for example. So, the TD booster is publicly funded, whereas the Tdap booster is not. TD booster is available on hand at our clinic, but for the Tdap booster, the patient would have to go to a public health unit. And the TD booster provides protection against tetanus and diphtheria, while the Tdap booster provides protection against tetanus, diphtheria, and pertussis. Tdap in BC is offered to all students in grade 9, however, PL was not in Canada during that time. Of note, if she was born in 1989 or later and didn't receive her adolescent dose, she would be eligible for the Tdap free of charge. But since she was born in 1987, in this case, she doesn't qualify. So in the end, PL states that she would like the TD booster and not the Tdap due to cost concerns, and she would also like the flu shot. We go on to inform her that the TD vaccine is recommended every 10 years, and if she decides to get the pertussis vaccination, she can get the Tdap booster anytime in the future, regardless if it's been 10 years or not. This is especially important if she does decide to get pregnant, as the pertussis vaccine is recommended for every pregnancy. PL also states that since the HPV and meningococcal vaccine are not provided for free, she will consider these immunizations in the future, but would like to know more about these two vaccines. So again, we go through the risk and benefits of each of the vaccine, And we end the encounter by providing resources and offer follow-up, which could be through telehealth if she needs further discussions. So to wrap up this section, the things we went over in this section include tips for finding immunization records if the patient doesn't know where to look, ensuring we involve the patient in shared decision-making and educate them on the risk and benefits of vaccines, and if no records are available and the client is unable to recall their vaccine history, you can recommend vaccination or revaccination as the benefit oftentimes will outweigh the risk. So when in doubt, recommend revaccination. Now back to Adrian.
Thanks, Tim. So I'm going to wrap up the presentation today by briefly discussing the topic of vaccine hesitancy, and then review some strategies for approaching or connecting with a vaccine hesitant individual. We all know that vaccination is one of the most important preventative health strategies we have, preventing millions of deaths worldwide each year. But despite the overwhelming evidence supporting their benefits, recent surveys still suggest that many Canadians hold negative or wavering views in regards to vaccines. As a quick review, the term vaccine hesitancy is used to describe the delay or refusal of vaccination despite availability of the service. When thinking about vaccination beliefs and attitudes, it's important to remember that vaccine acceptance should be seen as a continuum, and there's a wide range of beliefs and attitudes spanning from outright refusal to full acceptance of all vaccines. Vaccine hesitant individuals sit somewhere in the middle of this continuum, and their attitudes change over time and may vary depending on the vaccine. There are a number of factors which contribute to hesitancy, but in general, they fit into one of three categories. These include complacency, such as perceived low risk of acquiring the vaccine preventable disease, convenience, or in this case, lack of convenient access to the vaccine services, and finally, confidence, such as concerns around the safety of vaccine. As you can imagine, this is a very broad topic to cover, and so my plan is to share with you some main take-home points that we have found useful in our practice. The first point I want to highlight goes back again to this concept of a continuum when it comes to vaccine attitudes and beliefs. I want to reemphasize with the use of this model that the behavior of vaccination is not an all or none outcome. This is important to remember, as vaccine hesitant individuals should not be confused with true vaccine rejectors or anti-vaxxers, which are people with strong anti-vaccination convictions and make up a small proportion of the overall population. Estimates are that this is less than 5 or 10%. In comparison, the vaccine hesitant group makes about 20 to 30% of the population, and they are typically the ones you will encounter and see in your practice. Realizing this is important for pharmacists, as it can be easy to look at vaccine acceptance as this binary outcome and view everyone that declines a vaccine as an anti-vaxxer when that's simply not the case. And this assumption, in turn, may limit pharmacist engagement, thinking conversations may escalate into arguments or that we won't be able to change their opinions. This may lead to missed opportunities for vaccine-related concerns or questions being addressed. Worst of all, shying away from a conversation with these individuals may make matters worse. This brings me to my first main point, that failing to address the vaccine hesitant patient may perpetuate their concern, leading to more resistance for future vaccinations. The next point I want to focus on is the fact that there are many determinants of vaccine hesitancy. These can include contextual influences, examples including historic, socioeconomic, or cultural factors. It can be individual or group influences arising from personal perception of the vaccine, maybe from past experiences or social and peer influences, or it can be directly related to the vaccine itself. As you can see, there are a number of determinants, and it's unrealistic to ask you, a busy pharmacist, to find the root cause swaying one's decision away from vaccination. And so the point of this table is just to appreciate that vaccine hesitancy is multifactorial. And that is why there is no single strategy or intervention that addresses all instances of vaccine hesitancy. For the next 2 slides, we're going to explore some practical tips we found helpful when addressing vaccine hesitant individuals. Here I have shared one approach to this. Although this is not a validated stepwise process, reviewing the literature on vaccine hesitancy brings several key themes to light. And these steps here have helped us build an approach. First, inquire and explore. Inquiring about their vaccine hesitancy or resistance without validating or rejecting can be a starting point for conversation and building rapport. Second, identify determinants, specifically any determinants that could be due to misinformation. Misinformation is usually, but not always, the root cause of vaccine hesitancy. As an example, often cited misconceptions for the influenza vaccine include fear that the vaccine could cause influenza itself, or that influenza is not a severe enough illness to justify vaccination. And finally, focus. With limited time with patients, you cannot expect to change entrenched belief systems that may stem from things like one's culture or religion. And patient education should focus on changing the misconceptions that affect vaccination decisions. Other practical tips include: be ready to provide reliable sources of information. Memorize 1 or 2 websites that patients can turn to, like Immunize.bc, or have handouts or posters directing patients to these resources. Secondly, emphasize the availability of services. Offer on-the-spot vaccine opportunities, or schedule an appointment, or make sure to provide frequent reminders. Third, expose patients to positive messaging through various channels to provide education, whether that's displaying posters in the waiting areas, providing brochures, or sending emailed newsletters. And this brings me to our bottom line here, and that is that the majority of adults think immunizations are important, but do not have all the information to know which vaccines are required throughout their lives. Immunization schedules and information online can be difficult to navigate. However, research has shown that healthcare provider recommendations are one of the strongest predictors of whether patients get vaccinated. And therefore, as pharmacists, simply listening and possibly identifying some misconceptions and focusing your conversation can play an important role in addressing vaccine hesitancy and improving adult immunization rates. Consider your role as educators and health advocates to support individuals in making informed vaccine decisions. Be proactive and inquire about vaccination status rather than waiting for patients to voluntarily express interest. And consider incorporating some type of screening or assessment tool to help support your practice. On my last slide here, I just wanted to point you to some helpful resources. The one I wanted to highlight is the immunization communication tool for immunizers. As we've reviewed the fact that healthcare provider recommendations can be a strong determinant in patient decision-making, you must be confident in your messaging and be able to address misconceptions appropriately. This communication tool is a great document which helps answer the most common questions and misconceptions that patients may have. One column provides clinical evidence to support your message and answer, and the other column provides the key take-home points that the patient should walk away with. Other resources that you're likely familiar with include Immunize.bc manual and BC CDC immunization education and training website. And with that, that concludes our presentation. The live Q&A from October 22nd will follow.
Thank you, Adrian and Tim. So I do want to be mindful of everyone's time. That is nearing 7 p.m. If you do have to leave to other commitments, please feel free to do so. However, with that being said, I want to open up the floor to some Q&A. So you can use the Q&A or the chat. I will be checking both for questions. We do have a question here, Tim and Adrian. The Tdap, which includes pertussis, is publicly funded for adults. if that adult believes that they haven't been vaccinated for whooping cough. Is that true?
Yeah, thanks for the question. I think Tim, we were just talking about this yesterday. So I believe that is the case, that you are eligible if you think you've missed the booster. I think the last booster is in grade 9. And one thing that we did determine as well is that it doesn't matter the spacing from the last tetanus vaccine. So they did have a TD, and now you identify a need for this pertussis vaccine. You don't have to wait 10 years to give it to them. You can, they are eligible to get that vaccine right away.
Yeah, and to kind of just add to that, whether it's so the patient is eligible, but I guess one of the question is like, is this medication or vaccine covered for free? And so in the case of Tdap, when you go to HealthLink BC, it states there that this isn't provided for free for those who did not receive it in grade 9, unless you reach that requirement. That is, if you're born in 1989 or after, and if you missed your shot in grade 9, then it is for free. But if you're born before then it would not be covered for free.
Thanks, Adrian, Tim. And from my own experience working at the clinic, I think that cost and convenience are huge drivers in getting vaccines. So offering vaccines that are free of charge and offering it right on the spot ends up being quite the opportunity. Most patients don't really want to arrange further follow-up appointments to get that. Okay, we have another question. This individual had a patient that said she's heard HPV vaccine led to an overall reduced cancer risk of about 6%. Can we recommend HPV for any adult that is otherwise not at risk?
It's a good question. I'm hesitant to give any specifics on this without actually knowing for sure, but just keep in mind with the HPV vaccine, the recommendations are in place based on the fact the evidence is there to support evidence in that age group, in that population. And so there is an age outside that specific age group with the eligibility criteria, just realizing that if there is already sexual activity, which generally will occur outside that age period, the vaccine doesn't have the same benefits as it would for the younger age group. And so I think that's where some of that weighing the pros and cons might come into effect. I don't know if anyone else does off the top of my head whether that cancer risk reduction is specific for all patient age groups.
Yeah, and I think that just kind of speaks to the point where it's always important that we want to just double check our resources before providing any sort of recommendations or information to our patients. So again, Adrian listed some good resources that we can refer to when we're trying to figure out whether or not these questions or these statements are accurate.
All right. One question here is about the cost of the Shingrix vaccine. And I don't think we know that off the top of our head, but just my own quick Google search here from, again, a very reliable resource, Immunize BC, does indicate that it costs about $150 per dose. I don't know if anyone else on the webinar or Adrian or Tim can sort of validate that cost. No further comments.
I think I recall it being about $300 for 2 doses.
Yeah, and I have another individual confirming that it is about $300, almost $300 for both doses. Okay, thank you. And another question here about adult MMR booster recommendations, as it's difficult. That one's more difficult to clarify.
Yeah, and and I appreciate these questions, and this is something that we all deal with. I think, again, being a bit hesitant to answering these specific vaccine questions because there's so many nuances and things to consider. I think the best thing you can do in these situations is to really go to the BC CDC website. They have the most up-to-date eligibility criteria, especially those vaccine product monographs in section 4. But another thing I just want to bring up as well is if there is confusion around the criteria and you're really not sure, connecting with your local health unit, specifically the ones that you get the vaccines from, they are a great source of information and a resource to use, because they see these questions quite frequently. So if it is not clear enough from these resources, I would strongly suggest connecting with that local health unit.
Yeah, thanks, Adrian. And I think that point, connecting with local health units, checking online resources, might speak to our next question, was what to do with the patient who has missed a third dose of Hep B longer than 1 year, for example. Would one restart the vaccination?
Yeah, thanks for that question. So it's been an extended interval. So there is this general rule of thumb to consider that with vaccine intervals, it may be lengthened, but it should never be shortened, because you might get a suboptimal immune response. So for most cases, if it's late, you can still give it, and it generally still confers immunity, and okay, you don't need to redo all the vaccinations. That's the general rule. I believe that's also the case for the hepatitis B. I would have to double check, but there are, again, some exceptions. I think Shingrix and some of the other ones that haven't been studied to that extent yet, they still recommend that specific dosing interval. I hope that kind of answers the question.
Thanks, Adrian. Okay, more difficult vaccine questions coming your way. Should a patient who has GBS be vaccinated? And this comes from an anonymous attendee. I don't know if there's any clarification to the vaccine, or if this is just all vaccines in general. Might be specific to the influenza, but I won't make that assumption.
Yeah, that's a good question. I haven't been in that situation before, so I don't have any kind of clinical advice off the top of my head.
Okay, no clarification coming our way. Again, just to reiterate, I think all of the resources that have been provided here tonight are just such great tools. Okay, one more. How about HPV vaccine? If one is late for the third dose due to COVID, third dose is more than 1 year for the first dose, any concern? Adrian, I think this probably
again, this goes back to that first, thanks, Nikki, that first question. I don't believe HPV is one of those that you would have to restart the series. Again, we worry if it's too early and we don't get that immune response built appropriately because they're too close together.
Yeah, and I can attest to that. And so if it's a bit late before their next or final dose, you can go ahead and still give it.
Okay, seeing no further questions. Oh, we have one more question. Yeah, we have confirmation from another audience member, so that's always great to hear. All right, well, seeing no further questions, I really do want to thank everyone for joining us tonight, despite our technical difficulties at the start and our late start. It's 7:02, so we are ending relatively on time, and we wish everyone a great night. Thank you for joining.